Introduce Dr. Aman Sohal, a colleague of mine, a good friend. He is the founding partner and clinical director at Neuropedia Children's Neuroscience Center, a consultant pediatric neurologist and neurophysiologist at the same center. He's an associate professor at Mohammed bin Rashid University of Medicine and Health Sciences, and is here to talk to us about a condition that took me 3 years to pronounce, Aicardi-Goutieres syndrome and Pseudo-TORCH syndromes. So, Dr. Aman, please.
Thank you. Good morning, ladies and gentlemen. Assalamu alaikum. It's a pleasure to see you all on a Sunday morning. So I'm sure you really like to hear about rare diseases today. And I can see lots of pediatricians, lots of neurologists, and a few parents in there as well. So that's a really nice mix of audience. Now, pardon the slides thing because it's not on PowerPoint. That's why we have to just reduce it. And we're just going to make sure it's working fine. So what are we going to do in the next 20 minutes? We're going to talk about why we are here. Some of us, like myself, are for CME points only, but many of you are here to learn. And in neurology, there are two things which we always do: is where is the problem and what is the problem. So I'm going to focus on these two things in the next 20 minutes. I'm going to talk about TORCH, pseudo-TORCH syndromes, and AGS. Before I go into that, can I have a show of hands, people who have seen kids of Aicardi-Goutieres syndrome? So that's good to hear that there are a few of you who have actually seen the cases. Show of hands who have actually diagnosed or seen cases of pseudo-TORCH. Only one or two maybe, so you can see that the rarity even gets even more rare when it goes to pseudo-TORCH. Right, let's talk about this case. So this is a 9-month-old boy who presented initially to the hospital with a 2-week history of staring episodes lasting up to 1 minute, and then had these kind of focal seizures and was admitted to the hospital for further management. So from 9 months onwards, up until 2 years of age, when he first came to see me, he continued to have these focal seizures. And there were lots of tests being done on this child, but the diagnosis was not made at that time. So he came to our clinic for the management of epilepsy. Can you have a look at this child who looks a little bit odd, but we don't know what's going on, and can we have a unified diagnosis? He was born at full time, normal delivery, no complications at birth, but in terms of development, he had poor neck control, and he had severe axial hypotonia. So you pick him up at 2 years, and his head would just flop. He was not rolling over, he never sat unsupported, not reaching for objects, and basically the idea is that this child has got severe development delay in all modalities. We looked at him, and he was severely microcephalic. There was some subtle facial dysmorphism, may or may not be. I always send him to Dr. Ayman. He had some hyperpigmented macules, which were diagnosed as hyperpigmented macules on his lower lips, which later on we found out was something else. As we go through the talk, we'll talk about that as well. He was severely hypertonic now in his lower limbs and his upper limbs, and he has brisk reflexes all throughout. So, is this CP? So this child was referred to as saying that, could this be a CP child who has got something else going on that we don't know about? So what do I do now? So you're all, lots of you are pediatric neurologists, but there are a few here who I will just go through the basics of the talk as well. If you look at the neuroimaging of a child who is normal, you would come across this kind of a scan in which the grey matter looks light grey on the outside and dark grey on the inside. This is the flare sequence, which is a T2 sequence. T2 is normally this sequence, where the CSF looks white, but if you make it fluid inversion, the fluid becomes black in the middle, and in this scan you can see the grey matter on the outside, which is light grey, and white matter on the inside, which is dark grey. That's how it should look like. But this is our child's CT scan, which we did first. So have a look at the CT scan and tell me if it is normal or abnormal. And people who think it's abnormal, can you send, not the neurologists in the front, but there's some pediatricians. Did you pick up the abnormality there? Anyone? Abnormal. So what is the abnormality?
There is a hyperdensity in the basal ganglion.
Absolutely. Brilliant. Well done. So if you keep looking at this, I don't think this will work because of the digital screen, but you can see in the middle, in the basal ganglia, you can see these bright white spots in the middle, which is your basal ganglia, and you look at these bright spots, and you think there is something not right. So if you see that, what is that? That's calcification. So if you do a CT scan, people who are pediatricians and parents here, when you do a CT scan, if anything which is bright is either B for blood bone. So you're looking at bright blood, bone, or then this is calcium. So bone is basically calcium. So this child has got basal ganglia calcification. When we see that, as a pediatrician, what's the first thing we think about if a CT scan shows calcifications? Absolutely. So has this child got congenital infection of some sort called the torch? If there were residents here, I would have asked them what torch is, but there's no resident. So you're looking at toxoplasmosis, you're looking at rubella, you're looking at CMV, you're looking at herpes, and in some cases it was called torch S, if you're looking at syphilis as well. So that's the first thing you think about as a pediatrician when you see the CT scan. This child then underwent an MRI brain, and if you look at the MRI brain, what you'd see is, if I show you the first scan, the T2, it was full of brain. There was a lot of grey in there. This one is more white. So that tells us that there is a loss of white and grey matter volume. So basically this is a shrunk brain. If you look carefully, you will also see that the white matter, which should be dark grey on the inside, is actually not dark grey as it should be. So there is some white matter abnormality as well going on. So you look at this MRI scan and tell us, you see that, and you feel that there is something wrong with the grey matter, something wrong with the white matter, and now we also see the CT scan, there is calcifications in there. When we see such a thing, which I'll come to in a minute, we think about a certain condition. Now this is the second case which I came across. It's a 4-month-old boy, full-term normal delivery, and was in 3 weeks in the NICU because of some sort of ventilation and oxygen problems. Pretty straightforward history at that point. The NICU team didn't think much about it, parents didn't think much about it, but then the penny dropped at 3 days of age when he had his first seizure. So now we have a baby who was born full-term but has started seizing now at the age of 3 days. When we looked at this child, this was neurology examination was a little bit later, so it's not in the initial neonatal period, but it was by the time the baby came to see me, was a bit older. Anyhow, had normal, grossly normal cranial nerves, but again, the theme here is severe microcephaly, hypotonia plus, quite significant in his axial hypotonic, severe head lag, and this time the deepened reflexes. This baby was slightly diminished, but still present. And then at the age of 4 months, when I got to see this baby, was fixing momentarily, but not following. Parents felt that this baby is smiling, but I felt it was not consistent, symmetrically moving all lips, and had just started to raise the head when prone. So this baby, as opposed to the other one which I showed you, had slightly more advanced in terms of development. Still delayed, but still a little bit better than the previous baby. And this is the MRI brain for this particular baby. And in this one, you can see that the brain volume doesn't look too bad, but if you might miss these areas because the resolution is not great. But again, this also showed some white matter abnormalities, and there was some what we call as neuronal migration defect, and that's the picture will come through. Yeah. So if you missed it in the previous scan, you could see the grey matter, which if I'm a bit too close, but you can see the arrow there. That is an abnormality there, which suggests that there is a neuronal migration defect as well. So it's called grey matter heterotropia in this particular MRI scan. The previous MRI, which is not showing very nicely there, also showed white matter abnormalities. Now we have two similar kids here, and this baby also had a CT scan, which I'll show you in a bit later on. So we have two similar themes here going on with babies who were born pretty much okay, had microcephaly, but then also had some CT scan calcification and abnormal white matter. So, if I showed you these images of CT scan of different children, could you tell me which one of this is torch? Any guesses? The top one on the right, the middle one here, or the bottom one there. Which one is a torch infection? Could be everyone, exactly. So how do you tell which one is a torch, which one is a Aicardi-Goutieres, and which one is a Pseudo-TORCH? When you look at CT scan, you probably cannot. There are some markers there, but again, those are educated guesses. So that's a good point which I wanted to make here, is that when you do a CT scan, you can't tell whether this is torch or not. So as a pediatrician, the first thing you need to do is look for torch. When you haven't found torch, or you've got other clues in there, then you look for deeper. Anyways, the top right is a torch, the middle one is pseudo-TORCH, and that's your Aicardi-Goutieres syndrome. So what is Aicardi-Goutieres syndrome? Briefly, in the next 5-10 minutes, we'll talk about this. This is a condition which affects the central nervous system, affects your white matter, you get calcifications and abnormalities in your basal ganglia as well, which I showed you before. And what further happens to that is this. You get microcephaly. That's the first big handle when you look at AGS, is microcephaly. You got calcifications on your cerebral CT scan, particularly in your basal ganglia. You get white matter abnormalities, you get leukodystrophy, and then as the baby progresses, you get loss of volume in the white and grey matter. If you do these children's CSF, this is a pretty good marker in which you see raised alpha interferon. Has anybody done alpha interferon for Aicardi-Goutieres syndrome? So when I was training way back in Newcastle, we used to do that. But then since the genetics have come through quite nicely, we actually go for the genetics straight away now. And my colleagues will probably agree to that. The key other hallmark in AGS is the other things which happen in AGS, which are at the bottom of your screen, which is these chill blade-like lesions, usually on your fingers and toes. Does anyone know why does that happen? So if you go and read about AGS after this talk, if you're not bored and you want to do some bedtime reading tonight, you will find that AGS or Aicardi-Goutieres syndrome shares the lupus with another condition called lupus, SLE. And SLE presents with lots of problems with your rash and similar lesions as well. So that's the theory behind it in AGS. When you see these babies in the initial period, one of the biggest handle, and some of the cases I've seen with AGS, usually presented to us at the age of 4 or 5 months with fever, febrile episodes, thought to be meningitis. You do this CSF, and it shows leukocytosis. You see CSF white cells, but normal protein, normal glucose, and they're treated as meningitis. But actually, it is not. That's one of the markers which you see in Aicardi-Goutieres syndrome. So if you have a baby who's 6 months old, microcephalic, and coming with fever, you need to think about this condition. So you need to think about doing the scans to see what else is going on, because that's how they usually present. So neonatal seizures, poor feeding, calcification as I said before, MRI findings. You do their blood testing, you'll find that their platelets are low, they've got raised AST, ALT as well, and in some cases you get hepatosplenomegaly as well. As they grow older, they develop essentially signs of cerebral palsy when it comes to their motor skills. They become spastic quadriplegic, poor head control, and they start to have pyramidal and extrapyramidal symptoms because of the involvement of the basal ganglia. Some of the babies with Aicardi-Goutieres syndrome can also develop glaucoma, and that glaucoma can be present at birth, so be aware of that. And then we talked about the children lesions, which you can see very clearly in these pictures. I hope you can see clearly. And they affect the tips of your fingers and toes, and that's another hallmark which you need to look at. Okay, so there are 7 types of Aicardi-Goutieres syndrome, from 1 to 7, and they all, the genes which are mentioned at the bottom of your screen. If you want to take a picture or want to have a look at this, that's fine. So they present with classic AGS symptom, which I've already talked about. Some of them present with spasticity and dystonia. Some of them have bilateral basal ganglia striatal necrosis, and then also in some cases you can get cerebrovasculopathy, depending on which gene is involved. But again, the basics remain the same. The presentation remains the same. They kind of change or move as they grow older in terms of their symptomatology. How do you diagnose it? We already touched upon it. You do the normal TORCH screening and it comes back as negative. And then you do CSF, it can show lymphocytosis. If you do alpha interferon, it will show high levels of alpha interferon. I've never done neopterins in the CSF with AGS. I've done it for different reasons, but not for this particular. But it is an interferonopathy, which means your alpha interferon is going to be high. It's one of those interferonopathies. Radiology, we've gone through it before, so I will not spend much time on it. But as you already mentioned, the main key is the cerebral calcifications, which happen in this particular condition. 50 to 70% of cases in Aicardi-Goutieres syndrome, the calcification is not just in the basal ganglia, it can actually spread to the other sides of your brain as well. And that's one of the kind of bog standard CT scan, which we see in a child with Aicardi-Goutieres syndrome. So when I see such a CT scan and the pediatricians ask me the question that is this TORCH, I usually say that I doubt this is going to be TORCH because of the clinical findings and affecting of the basal ganglia in particular. Because in TORCH you see that it can be widespread around the whole brain. Same line on this, in terms of MRI brain, you would see the white matter abnormality which I showed you, similar to my patient, but this is how, if you can read, it's okay, the resolution is not too good, but you can look at that it shows bilateral hyperintense lesions in your white matter, suggesting leukodystrophy. Right, this is the key take-home message from this particular slide as well, that what are the possible treatments? So there are lots of options going on, lots of research going on treatment of Aicardi-Goutieres syndrome, depending on the gene defect. And there was this study which came out done by Yannick Pro, one of our founding members in terms of treatment of AGS. And they looked at these three particular medications, abacavir, lamivudine, and zidovudine, which is antiretroviral. And they thought that this could be one of the treatments which can be used in AGS. And they did this research over 1 year period, and they found some effect on the management or improvement in the clinical scenario. That's another thing which is coming through the JAK inhibition, the Janus kinase inhibition, and they have seen definite improvement in the TREX1 gene-related skin disease when it comes to the AGS skin lesions. So there's a lot of research going on right now in the management of interferonopathies, and this is one of that which is coming through. Okay, now in the next 5 minutes, let's just look at the pseudo-TORCH syndromes. Pseudo-TORCH syndromes, how do they present? They're basically also known as band-like calcification with simplified gyration and polymicrogyrate. So the biggest difference between pseudo-TORCH and Aicardi-Goutieres is that pseudo-TORCH syndromes also have a neuronal migration disorder associated with the cerebral calcification. So if you see that kind of thing, which is cortical dysplasias and polymicrogyrias, you should start thinking more about on the lines of pseudo-TORCH. Again, these are also recessive, autosomal recessive conditions, and they have intracranial calcification. They can also have systemic involvement, like the AGS, which is hepatosplenomegaly and enlarged white ventricles, thrombocytopenia, and then neurological problems in children or babies, just like the AGS spectrum. So the case which we talked about before, with the 4-month-old baby boy I was talking to you about, after the seizure, as the story unfolds at 4 months, he also had raised bilirubin, his LFTs were slightly deranged, he also had thrombocytopenia, and that's when the penny dropped that are we looking at something else rather than TORCH. We did his CSF, which was normal, we did his TORCH screen, which was normal, and then we later on found out that we went back into it to his CT scan, and if you can just, it's not clearly showing there, but it's showing very nice on this screen, there are some punctate lesions of the calcification in the basal ganglia, as well as in the subcortical and deep white matter. So when we saw that, we thought this is something else, this is not TORCH. And then when we did it, that's a scan I've already shown you, so I'll just skip that. But if you can just look at this part here again, you'll probably see very clearly the stratum and the abnormal looking white, the grey matter. Anyways, so we did his gene mutation, and we did his whole exome sequencing basically, and we found that he's got a homozygous mutation in the OCLN gene, which leads to pseudo-TORCH syndrome. So what is pseudo-TORCH syndrome? It's an umbrella term used for various conditions, and depending on the gene mutation you have, it is divided into pseudo-TORCH type 1, type 2, and type 3, and there are also forms of interferonopathies. So that's this quick slide to show you what the pseudo-TORCHs look like, or what are they, the kind of how they're present. And you got TORCH 1, 2, and 3, and all 3 of them have different gene mutations. I'm pretty confident and sure that in coming time, you will have more genes coming through, and this is going to expand. When we started looking at Aicardi-Goutieres syndrome, I remember we only had 2 genes, as TREX1 and SAPDH1, and then as time went by, we found out that it's now 7 genes. This is the same thing is going to happen with this particular condition as well. We've just recently found out the 3rd gene, not too long ago, maybe a couple of years ago, and that's how they're present. I won't go into the details of that because time is running out, but that's what the genes are and how they're present, which is fairly similar in all the pseudo-TORCH conditions. So what are the take-home messages from this particular slide? Common things are common. TORCH infections still remain common. Aicardi-Goutieres syndrome and pseudo-TORCH are rare. So if you see a child with a CT scan who's got calcifications, please look for TORCH infection first. And if that's negative and you have other features of microcephaly, you have features of hepatosplenomegaly, you have raised LFTs, you do their CSF and you find leukocytosis, that's when you start looking at these particular conditions. And if you also see systemic association, for example, chilblains or lupus-like lesions on a baby's hands and feet with microcephaly, start thinking about Aicardi-Goutieres syndrome. The final slide for my patient who's got Aicardi-Goutieres syndrome. Thank you to him for letting me do this. What I wanted to show you here is that even though they have a very difficult neurological condition, they still smile, they still want to interact with you. So that is the key home message here. Don't just think that this child has got a rare condition and all is doom and gloom. It's not. I've had a patient in Birmingham who had Aicardi-Goutieres syndrome and used to go to school. So, you need to work closely with the family. You need to do physiotherapy, speech therapy, occupational therapy. You've got to do all those things. Look after their seizures, and you never know that some of these children actually do quite reasonably well as well. And that will be all for today. Thank you very much indeed for listening.
We have time for one question. Anyone? Yes.
Thank you for your nice presentation. Have you come across a Aicardi-Goutieres case with later presentation as late childhood or adolescence?
Yeah, that's a very good question. So the kid I'm talking about in Birmingham, which we had, was actually twins from Pakistan, and they were 7-year-old twins, and they were diagnosed with cerebral palsy because the MRI scan just showed a slight bit of terminal zones white matter volume loss. Sunny is here, you know Shakti had these patients, and they presented to us with seizures for the first time at 7 years of age. The MRI showed CP kind of features, but the history wasn't quite right because they had microcephaly from very early age. So when they did the university, did their CT scans, I can't remember why we did them, or we did them, and we found calcifications. And those are the kids who actually used to go to school. So the presentation can be quite late because the gene is very heterogeneous and the presentation can be quite wide. So yes, the oldest I've seen is a 7-year-old child. I haven't seen beyond that.
Yes, but they have microcephaly since birth.
Since birth.
I mean, the new presentation, the first presentation in the late childhood with the SLA-like picture, but all the other features are suggestive of Aicardi-Goutieres.
I haven't come across that yet in my personal practice. The ones which I've seen, which I've mentioned to you, I'm sure there are people here who are much more experienced as well. They might have seen older kids. Anybody in the house wants to answer that question? Somebody's raising their hand.
Oh, thank you very much. I've seen a child with Singleton-Merton, which is a sort of in this range of disorders, and she came very late. So she didn't have microcephaly. She had more of the autoimmune picture.
And was she confirmed to have Aicardi-Goutieres?
No, she had Singleton-Merton. It's one of those disorders,
Yes.
but one of those genes, and it causes both conditions.
Okay, thank you.
Thank you.